May's CCG governing body being held in public is being streamed on YouTube. So anybody that's watching, thank you very much for spending your time this afternoon observing our proceedings. So there are a few new people on the screen today. So I just want to welcome Gavin Boyle, joined us last month on the 1st of April as our interim accountable officer. We've also got Laura joining us, who's providing the admin support this afternoon. So welcome, Laura, and thank you for supporting us through the meeting this afternoon. I've had apologies sent through from Brian Hughes, Alan Windle, and we've got Danny Hydes deputising. So welcome back, Danny, and we look forward to your contributions this afternoon. Apologies from Lisa Phillip and Amir. We've got apologies from John McElwraith. And then finally, I think we've got Nikki Normington on the call, and I understand, Nikki, that you need to leave at 3:30. So that has been noted. So I make the attendance this afternoon quorate, but Kath, can I just double check that with you that we are quorate and good to go ahead?
Correct.
Thank you very much, sir. Okay, so before we move on to the main items in the agenda, are there any conflicts of interest that anybody should be declaring at this point in the meeting? No. Okay, so just to note, any other conflicts of interest are generally kept on our conflicts of interest register, but there are no specific conflicts in the items on today's agenda. Kath, have we had any questions through from the public?
No, we've not.
So no received questions this month. Okay, so I don't have any particular opening remarks to make today. However, for the interests of members of the public observing the meeting this afternoon, we are in a pre-election period which will prevent us from discussing certain CCG business, and on that basis I will keep my remarks to a minimum this afternoon and move us straight to the first item, which is the approval of the minutes of our previous meeting. So that's item 5 on the agenda. It'll be in your packs and it's paper A. So if I could take us through those page by page, please. If anybody's got any points of accuracy to raise, please can you raise your hand and we'll bring you in at the appropriate point. So I'll take pages 1 and 2, please. 3 and 4. Pages 5 and 6, 7 and 8, 9 and 10, pages 11 and 12, page 13 and page 14, 15 and 16, 17 and 18, pages 19 and 20, page 21, and finally page 22. Okay, so I've not seen any hands go up, any corrections or points of accuracy to raise there. So we'll accept those as an accurate and true reflection of the last meeting. Take us now on to item 6, paper B in the noting pack, which is the matters arising from the previous meeting. So just noting on item 122/19, I've been made aware that there aren't any further updates on that item as it stands today. Item 9.22, which is the governing body assurance framework. I just want to check with Sandy that you're happy that that's being covered off on today's agenda.
No, so Sandy Buchan, Director of Commissioning and Development, because of PERDA in the pre-election period, that will be covered at the next public meeting.
Thank you, Sandy. Take us now on to item 10.22, which is the month 8 performance and delivery report. Judy, are you able to confirm whether you've had the opportunity to discuss ambulance response times at the Quality Assurance Committee?
We've got a full paper coming to the committee meeting next Thursday, Terry.
Okay, thank you. So I'll leave that open and we'll receive that at our next public meeting. Item 1122, which is just around the annual health checks. Lucy and Judy, could you just provide a quick update on that item? And it may be that that's coming to the next quack as well.
We've had a paper to quack, so I think we need to propose that we close the item actually, because we've discussed and agreed actions from the paper that we received.
Okay, thank you. So we'll recommend that item for closure. Item 1422 on the CCG due diligence progress report that was received earlier on this year. That item has been recommended for closure now. Item 2922 around the patient safety, quality and experience report. That meeting has been held and that's recommended for closure. There's a further item associated with that, which was for me to pick up a conversation with Ben Allen around behavioural sciences approaches. Ben and I can confirm that we've had that conversation and we'll be recommending that item for closure. And then the final item that we've got today is 3222, which is for the Director of Finance to provide a briefing on primary care capital investment once confirmation of funding is received. Jackie, I note that we've got that as an update, and I think the date for that was today, but just noting the pre-election period, is that something we'll be deferring to our next public meeting?
Yeah, I can just give a verbal update. So we have now had Treasury sign off of the South Yorkshire programme business case. So we've had the formal letter now. I haven't provided the briefing yet, but I will circulate that to members of the governing body.
Thank you very much, Jackie. So Mark, could I just bring you in, please?
Yeah, thanks. Just on that, can I just clarify, are we taking an update on that work to Primary Care Commissioning Committee or to here? Because I do think there are a range of issues associated with the work that we're doing there that are emerging through the communications and engagement strand that the CCG really needs to be formally advised on. So it's a point of just checking, where is the update going? Is it going to come here to the next governing body meeting, or is it going to go to Primary Care Commissioning Committee? Because I think there needs to be a formal discussion about progress.
So Primary Care Commissioning Committee is responsible for the oversight of the development of the business case, but in terms of our engagement responsibilities, the oversight is with Speak that would report into the full governing body. So I think it's there are responsibilities that governing body and PCC share. Okay, so what I'm suggesting is there's an action point maybe, which is that there needs to be a discussion about the approach, the issues that are emerging through the consultation, the involvement and consultation at Primary Care Commissioning Committee now. Which we would update at PCCC, but I think there's a role for governing body in terms of engagement oversight as well, which will bring a report back here as well on that. Thanks, Jackie. Thank you, Chair.
Thank you, Jackie. Thank you, Mark, for that point. So move us now to item number 7. So each of our governing bodies are usually started with a patient story or a story regarding some of the work that the CCG is doing out in communities. And this month we've got an item regarding some of the grants that we gave to community organisations to support winter pressures. And I'm going to hand over to Sandy, please, to introduce that item for us.
Thank you, Chair. So to give people a bit of a background and some context to this, in December last year, around £350,000 of winter pressures funding was approved to be distributed to the voluntary sector organisations in Sheffield. It was a light touch application and procurement process which was developed and saw applications through to contract award achieved in around 2 weeks. So it really is fantastic achievements, not only within the voluntary organisations, but within our organisation and departments as well. So this really did show the strength of that relationship between the CCG's commissioning, finance, contracting teams, as well as those strong partnership arrangements with Voluntary Action Sheffield and Rethink in order to achieve that process in such a rapid time. The voluntary organisations were asked to apply to support one or more of the following winter pressure priority areas, so such as urgent care, supporting hospital discharges, mental health including crisis pathways, supporting social care and supporting primary care. We received over 34 applications with 19 voluntary organisations across Sheffield being successful in obtaining some of that funding, which was to be used up until the end of March this year. And around 19 of those applications were forecasted to provide additional support to over 2,000 individuals. So it really is a positive impact for our population. Those impact reports we're now receiving to understand how the funding was used and the impact it's had, and to really give us some evidence base to continue this approach in the future. And what I'd like to present and introduce now is a short video from Manor and Castle Development Trust explaining the impact of their winter pressures funding together with the wider considerations over voluntary sector working. And before I hand over to Lucy to start the video, I just want to recognise James Sutherland, who did an absolute sterling job leading this work and really working with the voluntary sector to get this up and running and impacted upon. So thank you to James. But Lucy, could I ask you to start the video, please?
I just want to check. I'm not able to hear any audio on the video,
No.
Lucy.
Usual sound problem.
Okay, sorry. Share sound. Optimize for video. Click right. Second time lucky. I know it's that one. Right. I'll go back.
Hi, my name's Lucy Andrews. I'm from Manor and Castle Development Trust. We are a place-based charity based in the GPA1 primary care network area, and we deliver people keeping well and social prescribing. Our area is in the top 5 deprivation levels of the country. As an organisation, we use an asset-based community development model. We provide support from the cradle to the grave, and we find ways to improve the lives of people that live in our area in whatever way we can. So we applied for winter pressures money because the 25 years of development work that we've done in the area has given us insight, and we believe that access to healthcare is key. And we can't improve people's health if people are unable to participate. There's a lot of obstacles. Some of those things could be about poverty, not having phone credit, Wi-Fi, bus fares to get to places. There's health literacy issues, literacy issues. Sometimes people have multiple complex needs. They don't have one issue that meets the threshold so they could get health and social care support, but the multiple issues combine to make people's lives very complex, and it makes it hard for them to engage. There's all issues with people having a lack of self-esteem and confidence and voice to be able to navigate the system and get what they need out of the system. We've got a lot of people with undiagnosed learning difficulties, undiagnosed neurodiversity, brain injuries, mental ill health. There's a high proportion of adverse childhood conditions and trauma, and a lot of people with severe mental ill health that are not getting support. And this makes it harder for people to engage. So we used a community development approach. We set a team out. We said, go find people, help them to access healthcare in whatever way you need, and then make an impact. So this isn't about signposting. This is about supporting them with whatever they need and getting results. So I'd just like to share a case study to describe some of the work that we do. Jerry was picked up at a local community breakfast club. He'd had a letter warning that he was about to be thrown off his practice list if he had any more DNAs. He had some issues with remembering things and being disorganised. He'd got an eye infection that wasn't responding to antibiotics. So Kareem, one of our workers, made doctor's appointments with him, gave him telephone reminders, took him to the hospital when he had an appointment, helped to explain what was going on. When a tumour was discovered, she gave him support and kept taking him to those community groups so he could get focused on positive things. At this point, Jerry discussed with her a previous brain injury that could impact on his memory and some of his behaviours that were making it harder for him to access healthcare. She supported him to his operation, helped with a discharge and took him home. Since then, we found out that it is a malignant tumour and that he needs chemotherapy and will need support in order to go through that service. So we've been able to support through this project 56 people having intensive one-to-one support. We've supported 72 people in groups. We've had 68 people having some increase in their skills to access health, so things like understanding how to use 111, how to use the mental health guide online. And in a short project, we've been able to be really responsive and dynamic. After a couple of weeks of the project, we were having conversations with the Cancer Alliance, and actually I was able to say to the team, can you link in cancer nudges to all the people that you're supporting? So we've been able to have 134 cancer conversations with people that we've been working with. But importantly, it's not just about having a conversation, it's about providing practical support. So we've been able to say, have you missed a screening? Did you get a letter and not done anything about it? Here's my phone, here's the laptop, let's make that appointment. And when people have said that they're too scared to engage, we've been able to say, would you like somebody to come with you? So 13 people have been actually accompanied and taken to those appointments, which we believe they would not have gone to those appointments on their own. So this project was given £11,000 by the Ccg, and you can see the reach and impact that we can have and how we've been responsive and dynamic to the health and social needs within our primary care network. Since the winter pressure funding ended, we've continued to support Jerry and 13 other people who have high level needs through our advocacy team, and they provide one-to-one support with benefits, debt, housing, mental health, domestic violence and access to healthcare. But we have a £30,000 deficit this year for that project. This will be the same for other voluntary community organisations that as needs and demands rocketing, we're struggling to find funding to sustain our work. We are thinking about the future, and we've recently delivered a programme called Collaborate, which has brought staff from our area, from the three sectors, health, social care and voluntary community, and given them the space to be innovative, find ways to work together more effectively. And we're developing a report from that, which we'd like to share with you. We know that there are lots of challenges in health and social care, but we are excited to be able to demonstrate the positive impact that a sustainable VCF sector can have. Thanks.
Thank you, Lucy, for playing that video for us. I think there's some really powerful messages in that video, and I personally want to say thank you to Lucy for that contribution, and of course we will write to Lucy to thank her for that. Governing body members, are there any reflections or any comments you want to make on what we've just heard? So Lee, please.
Yeah, Lee Salisbury. I'm a GP that works predominantly in the north of Sheffield. So much of those stories sounded very familiar to me, and it's vital. I was talking to Chris Bentley, who is, as you know, it works very much along the lines of health inequalities from a public health point of view. And he quotes a really interesting piece of work, particularly looking at cancer survival. And actually the assumption is that people just are being diagnosed late because they're not turning up for their screening. And actually the study that he was looking at, which is in the Northeast, says it's not that people aren't being diagnosed, It's that they can't navigate the system once the diagnosis is made and they can't access treatment. So as commissioners, if we're thinking about best use of very, very tight finances, just hearing how little that project has cost and the impact it's had, I think that's really, really salutary. I think it's absolutely essential. I know in the GPA that I'm associated with, we're employing someone just to phone people up to make sure they get their learning disability checks. The impact has been huge. It's really easy, but it's very time consuming. But it's so effective. And I think though, we've got to think more and more along these lines about actually that really sort of community-based reach into people's lives has a huge impact and ultimately will save health a huge amount of money due to early diagnosis and better management of conditions. So yeah, thank you very much. I think that was a really helpful presentation.
Thank you, Lee. Chris, please.
Hello, I'm Chris Neal, lay member. I just wanted to also particularly emphasise how the voluntary and community sector has got that trust and that reach and that knowledge of where the need is, and also perhaps that acceptability that they're not going to be judged if they start to inquire about something that's wrong, and to actually sit alongside and go with and give some confidence and link to other networks that can make a huge difference than feeling you're told off, being more worried about going than not going. And it does make, as Lee said, a big difference to the health of those communities. And Manor and Castle, I know very well, has worked for many years with that wide agenda and particular health. And they pride themselves on that relationship with primary care. So thanks.
Thank you, Chris. Mark, please.
Yeah, thanks. My name is Mark Gamston. I'm a lay member on the Clinical Commissioning Group and the Deputy Chair of the governing body. I just want to take advantage of the fact that we have Gavin Boyle with us for 6 weeks or so before we disappear, because Gavin, in case members of the public don't know, is also the designate, I can't remember the accountable officer, the chief exec for the Integrated Care Board. Gavin, I mean, I just wonder what your views are. I suspect this is probably the first time you saw that video like us, but in terms of with the new integrated care system, what opportunities that sort of work might present going forward for us in the future, that relationship with the voluntary sector, light touch, relatively small amounts of money, generating activity that is directly relevant to the health service.
Sorry, I'm happy to take that. Can you hear me? I'm not quite sure. Can you just give me a nod if you can hear me?
Okay. We can hear. Thanks, Gavin.
No, really happy to respond to that, Mark. I mean, it's just an incredibly powerful story, and I think a great illustration of how relatively small amounts of money focused in a way that I think only the voluntary sector can achieve, can have such massive benefits for patients. So one of the things that I'm particularly keen to make sure that we do as part of our work as the Integrated Care Board, but in the wider integrated care system, is to make sure that the VCSE sector play a full part in that. And there's a number of ways that we'll make sure that happens. So on the Integrated Care Board itself, we'll have a partner member drawn from the VCSE sector, really just to keep reminding us about the opportunities that the VCSE sector presents. But I think particularly in the place partnerships, as you've done for many years in Sheffield already, I think there's a big opportunity to engage the VCSE as an equal partner within the health and care system. Because I think, if you think about some of the aims of the ICB around things like addressing health inequalities, then the way that you can go about that, and there was just such terrific examples. And I think, Lee's comment about, one of the main drivers for poor outcomes in cancer is not the kind of sophisticated end of things. It's just practically supporting people to be able to engage with the process. It just makes me think that, there's a massive part to play in achieving that aim of the ICP around health inequalities. So I thought that was a great story. That was the first time that I've seen that video. I'd love to have a copy of that, actually, just so I could watch it again and perhaps share with other colleagues if they were in doubt at all about the value that VCSE can play in what we're here to achieve. I mean, I hope that helps, Mark. But just to say, I think you sort of it's slightly preaching to the choir, because I think this is absolutely central to what we're trying to do.
Thank you. Ben, please. Not able to hear you, Ben. Are you able just to check your microphone?
You're a bit quiet, that's all, Ben.
Very quiet.
That's better. Perfect.
Okay, good. Take my headphones off. So yeah, I really just love the aspect of supporting patients to engage with the health system, and I think as all over the country the health system becomes more overwhelmed, then barriers naturally end up coming up, and it becomes harder for people to access. But also, some people manage to pull it off, and other people won't. And it's like, how do we support those people? And that potentially increases the health inequalities. So then there's this question of how do we support the public at large, but also particularly certain groups of people to just know how to have the confidence and have the skills to get the care that they need. And I think that's really, I think that's an area that I think would be great to develop, I think, because the health system is bewildering, and when you're in it, you know how to navigate it, and everyone else could really struggle, and with it changing so rapidly as well. I think that's really, so that I think that aspect of it was brilliant.
Okay, thank you, Ben. So I can't see any further hands up, so we'll begin to draw that to a close. Just thinking about our engagement, I am also aware that this was the first sort of full tender process where it wasn't done by kind of usual managerial colleagues in this. It was actually done by service users and members of the communities themselves. So I think there's something quite powerful in that as well, and I understand that that's being now embedded in many of the tender processes we undertake in the CCG. So I think from an engagement perspective, that's powerful, and really helps us get back into touch with the communities we serve. And before I close the item, Leah, your hand went back up there.
Yeah, sorry, at the risk of sort of repeating things, I think it is worth just drawing out the point that was made, that this isn't about signposting. It is about accompanying and helping people navigate, and there's a huge difference. And I think sometimes we signpost thinking that's enough, and actually it's not.
Yep, thank you, Lee. So thank you, Sandy, for introducing that. Thank you to Lucy for the video, and for James bringing all of that together for us. Okay, I'll move us now on to papers for approval. So item 8 on the agenda, paper C, is the adoption of the unaudited financial accounts for 21-22 and the financial report at month 12 of 21-22. So going to hand over to Jackie Mills for that, please.
Thanks, Terry. So I'm Jackie Mills, I'm Director of Finance for the CCG. So this is the final report on the financial position for 21-22, and it is in 2 parts. So the first part of the report covers the adoption of the draft accounts for 21-22, and the second part covers the final month 12 finance report. There's just some key elements from the report that I would like to bring to the attention of governing body members. So in terms of the accounts, the draft accounts were submitted to NHS England in advance of the required deadline of the 26th of April, and the external audit of the accounts started in the following week. So the intention is that the Audit and Integrated Governance Committee will meet on the 26th of May and will receive the post-audit financial statements together with a report from our external auditors, KPMG. And the audit members will have an opportunity to consider the accounts in detail at that point. On the same day, the governing body is due to meet in the afternoon following the audit committee meeting, and will receive a recommendation from the committee and be asked to formally sign those off. So as in previous years, we've provided an explanation in this report on the main statements included in the accounts and the key issues for 2021-22. And so today, governing body has been asked to note and adopt the unaudited accounts. And then in terms of the second part of the report, the key things I would just like to pull out is, subject to that external audit review, I am pleased to report that the CCG expects to demonstrate that we've achieved all our financial duties for 21-22. We expect to report a cumulative surplus of 22.8 million. That's made up of the surplus that we brought forward at the start of the year, which was 21.9 million. An in-year surplus generated by the activities of the CCG of £11,000, which I hope you all agree is a great achievement, given that we spend over £1.2 billion a year. So delivering pretty much the required position. And in addition, because we are the host to the South Yorkshire and Bassett Law ICS in the current financial year, there is a surplus of 886,000 relating to the ICS operations that we report as part of the CCG position. In terms of the report, the key issues on the various budget lines are outlined. I can confirm that the CCG met its obligations in relation to the mental health spend. So we increased our spend by the minimum required of 3.82% and exceeded that slightly. And as previously reported, the main pressures that we've had to manage in year have been mainly around continuing healthcare. You'll remember that in the second half of the year, we did rebase that budget to eliminate the overspending in the first half of the year and reset the budget for the second half. We still ended up with a £2 million additional pressure in relation to that, and in private we're due to have an update on the financial plan, and CHC pressures are a big feature moving into the next financial year. The prescribing expenditure was slightly increased above the forecast, but that still includes 2 months of estimated figures, so that could still change. And then finally, I've set out in section 7 the budget movements that require approval of governing body. So I just want to draw your attention to those that are set out in section 7. So they're the main points I just wanted to bring out from the reports, but I'm happy to take any questions.
Thank you, Jackie. Any questions from governing body? I think it's the first, I was going to say it was the first big finance paper, Jackie, you got away with no questions, but Anthea's hand's gone up. So Anthea, please.
So I was trying to find my hand and I nearly gave a thumbs up and said, Jackie, I just wanted to say, I'm Anthea Morris, I'm the lay member for Audit and Governance and Chair of the Audit Committee. Jackie, I just wanted to say thank you to you and the whole team for producing these accounts in somewhat uncertain times, although we're used to difficult circumstances at the moment. It's almost taken as weird. But I know how hard it is to produce the accounts to the timetables, which aren't usually published until the day before the deadline, and getting them and achieving all of our targets for the year as well, which shouldn't be underestimated. The difficulty of landing a £1.1 billion budget on £11,000 is something that our other government colleagues could take note of. So thank you very much for doing that and producing all the accounts. I just had a question about how the ICS surplus is represented in our accounts. Is that represented as our surplus, and what do we think were the reasons for that surplus?
Yes, it is represented in our accounts. The reasons, as ever in the NHS, there was quite a number of late allocations that it was proved really difficult to spend given the notice required, and there was a return of some slippage in terms of some investments that haven't been enacted in the line with what was expected. So, but again, on the level of spend that has been allocated in with very short timescales, I think it was a result to be able to deliver that level of surplus.
Thank you.
Thank you. Any further questions? No. So governing body is being asked to adopt and approve these unaudited accounts. Are we all happy with that position? Thank you. And we're being asked to note the final outturn for 21-22 subject to external audit. So again, can we note that? Jackie?
sorry, a recommendation was omitted. I apologise. Could I also ask that we approve the budget changes as set out in the report?
Okay, again, governing body happy with those budget changes in section 7 as outlined. Okay, Jackie, as always, thank you for all of this hard work, and in particular to the finance team, that I know it has been a year of moving goalposts and uncertainty, and it has been really, really difficult. So please pass governing body's thanks to the finance team for everything they've done. I've also got a note here from Brian Hughes, who's not able to join us today. But I think Brian outlines this perfectly, that year on year, the finance team managed to land a jumbo jet on APIN, and he just wanted to send that thanks on and really recognise the hard work that's gone on. So thank you, Jackie. Brilliant. Okay, move us now on to item 9, that's paper D. So this paper is coming for consideration. But the report itself is in draft form. Just want to note that this will be coming to a formal governing body later this month, where we'll be able to have a much deeper dive and much more discussion about what's in the annual report. So for that reason, we've only allocated 5 to 10 minutes for discussion today. But I would like to hand over to Kath just to introduce this paper for us.
Thank you, Chair. So I'm Kath Tilney. I'm the Associate Director of Corporate Services. And I'm going to be, as Terry's just outlined, presenting the annual report, the draft annual report for 21-22. It's included in your noting papers because it's a very big document. I wanted to start off by thanking the many staff across the CCG that have worked really hard to pull this together. It's a great document. We have a statutory duty to produce an annual report, and much of its content is naturally mandated. It has 3 sections in it: performance report, the accountability report, and the accounts, which Jackie has just covered off. So it's draft, but really it's a very complete draft, and there's just some information that we can't include at this time. For example, the attendance at this meeting here. No, actually, no, that's not true, because we've gone past the date. So, but there are some things that we can't include because we didn't have the information at the time. But yes, it's very nearly complete. The draft is currently sitting with NHS England and the external auditors for review, in the same way as we talked about the accounts. What the annual report does give us is an opportunity to celebrate many of the great achievements over the year that's just gone. And given this will be the last report from Sheffield CCG, we've taken the opportunity to include a small section within it reflecting back over the 13 years of being the CCG, using the material that was gained from the session we had at governing body, and also across the whole organisation. We had lots of sessions to look at what we were celebrating. As I think Terry mentioned just earlier, we'll be presenting the final version at the end of May, and the plan is that we follow a similar format as last year, and we bring our staff in to present the report and share with us what they're proud of, using some of the key headlines that we have in there. So that's all I was going to say at this point. Thanks.
Thank you, Kath. Are there any comments? I recognise it was a very long paper, and I'm assured that you will have all read that in detail, but are there any comments or points that anybody wishes to contribute at this stage? Lee, please.
Thank you. Just to say thanks, Kath. It was a good read. It's made me feel quite sad to think, oh, this is the last CCG report, and it was quite helpful to look back. There was a lot of stuff in there, a lot of sort of innovation. I think some of the highlights for me were the success of the vaccination programme. I mean, that is just fantastic, and that's a system coming together really well, and being well led. I think the innovative work was really interesting. The cancer support hub, the stuff that the primary care development nurses are doing, as well as working in the midst of a pandemic, was just amazing, really. I think those are interesting. I think there was an interesting thing about the benefits of people not commuting. And if we're thinking about climate change, the level of CO2 emissions being reduced, that was quite an interesting point that's worth us sort of reflecting on. And just one slightly cheeky point. I did notice on page 13 that the CCG is described as one of the city's best loved good causes, because it were included. So that just might be worth just having a bit of a look at. But it's quite nice to think that we might be a well-loved good cause. So thanks anyway to all the team for doing this. Thanks, Lee. Jackie, please.
Yeah, it probably just follows on from what Lee says. I think there is a temptation because the contents of the annual report are quite considerably nationally mandated to just do the bare minimum. And I think it's a really positive exercise, particularly where we are at, just to take that time to reflect and see all the, the massive amounts of work that our teams have done. A lot unscripted, undirected. They're clear about what they want to achieve, and they make sure that they do it. So I think when we do have the opportunity at the end of May to really celebrate their good work, it is a positive thing that we can share more widely with our public, to which we're accountable.
Thank you, Jackie. Any further comments or questions? Okay, if there are any other points that anybody has, please contact Kath directly. We can get those contributions in there. But as Kath's pointed out, recognising that we've all contributed to that report through previous governing body meetings, and also everybody in the organisation has contributed through a series of workshops and events in bringing forward some of those things. I think it's a lovely report. I think it does really outline our journey as an organisation, going back to pre-2013 when it was established, how things have changed, those real trusted relationships that we've built up with partners in the city, and in particular with the local communities that we serve. And I think there's something really powerful in building upon that as we move forward into integrated care in the future. So thank you, Kath, for bringing that. And I think we'll look forward to hearing from you, and hopefully from many of our staff that have contributed some of that great work later this month. Thank you. I'm going to take us now to item 10 on the agenda. That's paper E. So that's the month 12 performance and delivery report, and back over to you, Kath.
Thank you, Terry. So the purpose of this report is to provide information regarding the key performance measures of our providers. We look at staff use and experience, and update on COVID. For most measures, the position is up until the end of February and sometimes March. Also included in this report is the position against the operational plan, which takes up to which was the second half of the last financial year. So we're looking back into last year. As usual, I'm going to assume that governing body members have read the paper, and I'm just going to highlight a couple of key points. So the first area to highlight is a couple of the performance areas in the NHS constitution measures. In February and March, we were continuing to see the pressures in the system and the impact of Omicron on performance, and the link to frontline staff sickness and isolation, and the restricted bed and theatre capacity. In some of the areas, the position has worsened compared to last time I presented this report. For example, increased numbers of people that are waiting more than 52 weeks for non-urgent surgery, but we have had some areas where we are seeing some signs of improvement, and we're seeing that in some of the cancer wait measures are starting to look like they're going in the right direction. As reported in national press, this is a similar picture that we're seeing across many parts of England. As previously reported, we're starting to receive some more information now that was paused during the pandemic, for example, the mixed sex accommodation and a couple of other measures. And with those, we now need to establish how Sheffield providers compare to other similar providers, and understand what these post-pandemic trends are looking like. So we need to do a bit more work analysing that data as it's coming through. The national delayed transfer of care data flow still hasn't restarted, and as I think we discussed this at a previous governing body, that we wanted to bring in an interim measure until that flow was back running. So we've done that, and we've included in the report the average number of patients who meet the criteria to be discharged compared against a target. And that target is a 30% reduction compared to the position it was in December 21. Delayed discharges are a particular challenge for the Sheffield system at this time, and they cause longer hospital delays and longer hospital lengths of stay, and have a bottleneck effect, which impacts many parts of the system. So there's some detail in the report around this, but basically it outlines there is a citywide plan in place to tackle this issue that we've worked up with our partners. The second area that I wanted to highlight links to Ccg Workforce. You can see in the Workforce report section that despite the impact of Omicron, which has affected staff, we've still had a reduction in sickness absence in February, and then it fell again in March, which is interesting. And this has been mainly due to reductions in long-term sickness absence. We can also see that for mandatory training in all areas, there's a compliance rate of more than 80%, which is excellent. And we had a bit of a push on that, and really thank staff and governing body members, I'm sure, for making sure that we've achieved that. We've described before, there are lots of processes in place to support our staff with their wellbeing, and we continue to prioritise this very important area. In the latest staff temperature check, which the results are provided, I think it's the March figures are in the report. We use the temperature check as opportunity for staff to tell us about how they're doing, what's working well, and also what's not working so well. And we have generally around a third of staff that complete that each month. And one of the key themes that came out of the March survey is how much staff are still really appreciating working from home and the work-life balance that gives. And since April, we are actually being able to open up the headquarters office, and we are having staff trialling the home working policy in a bigger way, and the numbers really are starting to go up. So we're learning from that, and I know a lot of people are really appreciating catching up with colleagues actually face to face that they haven't seen for a long while, and there's lots of benefits that brings. So we'll be working to understand what's working well in that and what isn't, and so that we can shape all that together. But it gives us a really good opportunity to have those connections and the benefits that you get from working in that way. So those are the key areas I wanted to highlight. But very happy to take questions, but I may have to pass them on to others in some cases. Thank you.
Thank you, Kath. Any questions or any observations, please, from governing body? Mark, please.
Yeah, this is probably just me showing my ignorance here. The information around Yorkshire Ambulance Service, where the performance, I think, in terms of response times for category 1, I think emergencies, is slightly worse than the England average. I think that's how I read that. But the bit that I just want clarification of is that Yorkshire Ambulance Services performance as a whole, or is that specific to Sheffield? And then depending how you answer that, I've then got a supplementary question.
Kath, are you able to answer that, Kath?
I'm not sure. I'd have to check that this time. I'd have to check that. I don't want to state anything that is wrong. Yeah. So I would have to.
Mark, I'm just wondering at that point whether any members of the Quality Assurance Committee might be able to comment on that figure in more detail, because that will be something that does go through the Quality Assurance Committee. So Judy, Danny, are you able to shed any further light on that?
Judy, do you want to go or shall I go?
You go if you like, I don't mind.
I believe I believed it was as a whole, not just from a Sheffield perspective.
That's really helpful. Yeah. So I now have a supplementary question, right? Is one of the things that worries me, aside from, is I think it's quite right, and governing body members will have heard me before always ask that we compare our performance with others. and in this case, the England average. What worries me is if it's Yorkshire as a whole, that's a huge geography. And therefore, what concerns me is that emergency responses somewhere up in North Yorkshire, where there's a big rural, huge, few people live there, it's not very urban. The responses there would be, I assume, would take longer, which would then push our average up. And in fact, therefore, if we were to look at an urban response, we might find that Yorkshire Ambulance Service in Sheffield might even be less in terms of response rates than the England average. That was my thinking. And I just worry sometimes because obviously we are concerned about Sheffield performance. And I'm not sure that represents it. But other more informed people will now come back and tell me that I don't understand statistics or this, but that's my query, really.
Thanks, Mark. I think what we could do is ask the quality team to contact Yaz and see if there's any breakdown that we could look at here. I know several years back, the same question cropped up, particularly around the stroke bundles, and we weren't able to get kind of data that was drilled down to Sheffield or indeed South Yorkshire level at that point. But if somebody from Quality Assurance Committee or the quality team could just check in with Yaz and see whether there's any way that we can kind of have some non-aggregated data to answer that question, that would be very helpful.
Thank you.
I'll take that action, Chair.
Thank you, Danny. So Laura, could you put that on our Matters Arising Action tracker, just so that we can bring that back? Thank you. Jackie, please.
Yeah, so just to follow on, so that's my understanding that the figures quoted are at a provider level, but some of the information we do know is that the ambulance handover delays are reported based on Sheffield providers and the local position. We know that there are significant issues in terms of that. We also get data on the growth in terms of number of calls to the different categories of calls, and also growth in terms of 111, which have increased significantly over the pandemic. So there are significant amounts of pressure that are being felt in Sheffield. So historically, whilst the performance in Sheffield probably is slightly better than the Yorkshire and Humber average, there are particular pressures that we are in active discussion with the Ambulance Trust about how we mitigate some of those issues.
Thank you, Jackie. Judy, please.
And just to follow up on that, further to, Judy Thorley, lay member and chair of the Quality Committee. The paper that the committee is going to receive next week has got detail for us around how the ambulance service themselves look at patient safety and any learning that they can take and do take from the high weights, and that's recognising and response times, and that's recognising the significant issues that have impacted due to COVID-19, etc., etc. But we've requested assurance that there is no harm to patients, and that learning is taking place, and that's being embedded across.
Yeah, I'm sorry. I want to. This still is on the ambulance issue. I suspect other people have got their hands up, maybe for other things. Can I just?
Do you want to just ask the question about the ambulance, Mark?
Yeah. So the ambulance handover delays. I think the key bit, and I'm sure that Jackie probably meant this, are probably at least as much to do with the performance of the acute hospital in terms of people getting out, enabling people to get out of ambulances, as it is to do with the acute trust. I suspect it's mainly to do with the performance of the acute trust, actually. And that's how we must frame that.
Yep, thank you, Mark. I'm just thinking as well, Judy, we're kind of looking here at a reported performance metric, and I think both Mark and Judy will agree that we do gather quality data, particularly what we might consider soft intelligence, but that quality data from user experience is a really important thing that we do triangulate against. our performance on a regular basis. Gavin, do you want to come in at this point, please?
Well, I think Mark's probably already made the point, really, which is I think when you're looking at ambulance response time, it is useful to look at it together with handover delays, because one of the reasons why response times are long is because crews aren't on the road because they're waiting outside of an ED. But you do have to look at the whole pathway. So if you're looking at rather than looking at single indicators like ambulance response times, you need to look at that with ambulance handover, the duration within the ED itself, and then at the end of the pathway in terms of discharge delays as well. You do have to look at the whole thing really to get a kind of a faithful picture of what's actually happening.
Thank you, Gavin. It's helpful. And as you point out, it's looking at the system in the round, isn't it? And that's where we'll begin to hopefully address things. But in addition to looking at the system as in the round, it is about the system in the round responding, isn't it, rather than individual elements of that. So that's helpful to hear. Any further questions or observations for Kath, please? Nope. Okay, thank you. So there's a slight change to the agenda at this point. So item 11 was due to be an oral update on safety, quality and experience, but there won't be a report received at this month's governing body in public. So I'll move us on to item 12, paper F, which is the governing body assurance framework update. That's going to cover quarters 3 and 4. And right up until the end of March 2022. I will say this, and I always say this when this item comes, and this is probably one of the most important documents for us as a governing body in ensuring that we're meeting our obligations and mitigating against our risks. And it's back over to you again, Kath.
Thank you, Terry. So you've stolen my introduction, so I'll move on to the next.
I apologise.
Thank you. So as Terry says, I'm presenting the quarter 3 and the quarter 4 review position for GBAF, which due to timing of meetings, we're bringing them together, but they have been shared and discussed separately with the audit committee and with our senior management team. The report also discusses the approach to quarter 1 for this current financial year. So we've had some really good discussions before at governing body around the GBAF, and it really feels like it's come to life over the year, and we've been recognising that we've got increased number of higher scores risks than would be traditional in years past. This is still the case with the report I'm showing with you now, and it's reflective of the impact of the high pressure that systems under that we've just discussed in the previous report linked to the pandemic. So the key points that I wanted to just note are we have 26 risks on the GBAF, 4 of which just scored as critical and 5 as very high. There are no risks that have reduced in score in this period, but 2 have increased. The 2 areas that have increased are risk 2.1, which is linked to local organisations meeting quality standards. And this has increased due to the publication of the CQC report for Sheffield Teaching Hospital, which had the overall rating of requires improvement. This risk also has a gap in control reported, which is linked to the national COVID legislation removal of provide performance and the quality surveillance requirements that took place. However, that has now come back in again from the 1st of April, so that gap has now been removed as we move into this year. The second increased risk is 4.1, which links to our financial challenge, and that has been increased due to the uncertainty regarding the post-COVID landscape and the lack of clarity on some of the national financial frameworks. The report describes the work that's been undertaken to complete the actions that were recommended by internal audit, and also actions that we've agreed in governing body or audit committee and the senior management team. Since the report was written, we have received the interim head of internal audit statement from our internal audit team, and that concludes that there is significant assurance that they've provided linked to our sound system internal control, and GBAF is one of the key elements of that. We've had feedback on the report from Audit Committee, and will ensure that in the Q1 review we focus on risks where the scores haven't reduced even though all the mitigating actions in those risks have been completed. There are currently 6 risks that fall into this category, and for most of those there are clear external factors, but we're going to do a real close look on that to make sure that there isn't anything that we extra that we can do. Finally, the report describes the process for Q1 and the establishment of the opening risk scores. Most risk scores remain the same as Q4, but there are 3 that are different than those listed in section 5. So the plan is to bring a report to the governing body meeting in June, which picks up the Q1 review, and we'll also discuss the next steps for how the Sheffield CCG GBAF and corporate risks will be picked up and managed as we move forward into the new integrated care board from 1st of July. I think that covers everything I needed to. Happy to take questions.
Thank you, Kath. So any questions, and in particular being asked to consider and accept this report. So are there any considerations any governing body members wish to bring up? So Chris, please. We've got you on mute, Chris.
No, I'm trying to get it off. Sorry. Yeah, thank you, Kath, for an excellent report. It's difficult read within the context, isn't it, of in terms of some of the risks that haven't been there. Just an observation from reviewing it recently, which we all recognise, although I think we've put some of the mitigations in, the account of the wider context and the influence on that. And in my view, some of those risks could have been a lot worse without those mitigations. There's some of the things we put in place in terms of investment in communities, through the voluntary sector, in uptake of vaccination, and achieved much more than some areas in the circumstance. So, you can see those, even with our best efforts and mitigations achieved. I mean, we need to look into it more, but in the past when, for example, some of the inequality scores haven't moved, our regional report also indicated that if we'd have gone along the same trajectory as at the start, it would have been much worse. So it's really difficult to quantify in public health what you've prevented. I think the other thing that I think I'm assured about, but I just wanted to point out that, especially around the quality issues, and I think we can be assured that it's top of the agenda, but we're in a period of transition to a new structure, and those relationships with those organisations. So it's concerning that that's a high risk at this time when we're going to new personnel and different structures. But I know I do recognise a lot of relationships will be maintained, but just to keep it, I'm pleased that it's high up there of being identified as a risk that we need to focus on. I don't know if Kath wants to say any more about that.
No, there, Chris. Important observations. I've just two things really in the report that I wanted to pick out. I think we've recognised the reporting period that Kath has mentioned, and drawing out first bit relating back to what Chris has said. There are so many things that we'll never really know what would have happened had those mitigations not been put in place, but the assumption is those risks would have increased. So I think there's something about keeping many of those risks stable over the course of the 12-month period. I would like to draw out that I've counted them, I may be wrong here, but there's at least 5 areas where the risk has significantly reduced in year. So I think, you know, we should be recognising the work of the organisation then. And then finally, just to draw out Kat's comment from the internal audit, which is the significant assurance around the work that we've been doing over the last year, and in particular the work through the GBAF. So Kath and team, thank you, because I recognise that this is a really difficult piece of work to pull together, but as I said at the beginning, and I'm sorry I stole your thunder, it is one of the most important documents that we look at on a regular basis here. Sandy, please.
Thank you. So just linking with what Chris said about the time period and the inequalities, and even though the risks for the inequalities, and particularly in primary care, remains high, I think linking back to our video right at the start, looking at those grants and working with our voluntary sector during the winter period, which is what this reporting period is for the GBAF, really demonstrates the amount of work, effort, integrated working that we've had across Sheffield to really try and mitigate some of these risks, but very much demonstrating the level of pressures that we're still facing as a system in that current time. And after Anthea's spoken, it might be an idea to just bring in Zach, our medical director, or one of the GPs, just to touch upon the continued pressures that we are facing in primary care.
Thank you, Sandy. I think that's a helpful suggestion. So I'll take a point from Anthea, and GPs, maybe one that we've not heard from yet. If you want to put your hand up, it would be helpful to hear about some of those pressures. So Anthea, please.
Thank you, Anthea Morris, lay member and chair of the audit committee. More couple of points for the public. Look, one audit committee has been through this paper. We've fed back and we had time to put that feedback in before that paper was published for the public and the governing body. And two, that our risks are higher than we want. We will absolutely say they're higher than we want, and that is in no small measure due to the pandemic and due to the changes in our structure that are coming up that are affecting our staff. But they are not at all out of step with other CCGs, both in the patch and nationwide. And we've got that reassurance from our internal auditors who audit more than one CCG, so they do see a wide range of organisations. So they are higher than we would ideally like, but that is what you're seeing across the whole of the country at the moment.
Thank you, Anthea, and very helpful observation there. So I've not seen GP hands go up, so I'm looking to you, Zach, just to sort of give a summary. Actually, the hands have all gone up, so let's hear from David and Zach, and then we'll bring Lee in towards the end, if that's okay. So David, please.
Hi, I'm David Warwicker. I'm a GP. I work in North Sheffield. So pressures on general practice primary care. It's not about COVID. It's not about people with COVID. There's a combination of a backlog that we're trying to work through, people who've been very patient about long-standing problems. There's been the complications of those long-standing problems getting worse and progressing as they've, as people have been sat on that, and so there's a lot of stuff, physical health, mental health stuff that we're trying to work through. There's a lot of need. Sometimes in our profession we talk about demand, but it's need, patient need, that we're trying our best to deal with. There's also issues with staff. So staff are burnt out, doing their best. Sometimes coming up against a lot of criticism, both directly from patients and the profession coming across a lot of criticism from the press, from comms from sort of other places as well. I think there's people are leaving, so there's an issue of what's the word, retention, staff retention, and also recruitment, like who would want to work in that environment as well. People going part-time, people retiring earlier than they were planning as well. So there's a lot of so we talk about demand and supply as an issue as well, and that's not a problem that's going to change immediately in terms of sort of numbers. I think that there's also an issue with solutions that we've come up with to try and meet some of that need. So, for example, that there used to be an expectation that you would bring up and see your GP that day, and I think that there's a lot of stuff out there about people, people having that sort of need or that entitlement to see their GP. And the problem is that that there aren't enough GPs for everyone who wants to see their GP that day to see a GP. And so there are allied health professionals, people like, we have in Sheffield, we've got this great service, for example, in terms of doing home visits. We have the paramedics, the visiting service with a link to supervising GP and things like that. So there are solutions that we've got there, but I think there needs to be, and I guess I'm speaking to the public really, that there needs to be a sense of understanding that we're trying to sort of meet the needs of our patients, but it might not be the old-fashioned sort of, it's a face-to-face appointment with your GP and you have to ring up in the morning and see the GP, and understanding from the public that we are trying to meet our patients' needs in a way that isn't the conventional old-fashioned way. That's really going to help us. Thanks.
Thank you, David. And I'm just sort of trying to keep our comments in the context of the GBAF there, but I think it does really begin to address the context in primary care, and maybe explain why some of those risk scores have not gone down. So if we could take brief points from Marion, Nikki, and then Lee, and we'll move on to the next item.
I'll be quite brief. I think Sheffield in general is benchmarked very well, and I think we should be proud of ourselves for what we've achieved with the vaccine programme. So, there is a lot of this, inverted commas, doctor bashing, and it's misplaced, and it just destroys morale. The other thing that I think we do have to recognise is our additional medical colleagues, allied professions to medicine, because this is where the growth will come from. The funding is there in the hands of the PCNs. They know the needs of their patch, and we are learning how to work with a whole team of new people who can help us to take the workload off the GP. Everybody thinks they need to see the GP, but they don't. Yes, it's recruitment, retention. We're looking now for a partner, and we're going wider and wider with that net. We do need to think outside the box, and it was so heartening to see the presentation from the voluntary sector and the achievements that they can do with small amounts of money. We think it's all about money, but they can really capitalise on the investment that is put their way. Last point, I don't know if people watched the television with Davina McCall on Monday, but that is a combination of criticism of primary care, increasing expectation, looking to us to look at the workforce, the workplace, and in addition to individual women's needs going through the menopause. So there's loads of work out there to be done. We're ready to do it if we've got headspace to be able to develop those new areas of interest. Thank you, Terry.
Thank you, Marion. Nikki, please.
Thanks, Terry. Yeah, really brief, and this is for public, and just to make sure, because I'm not quite sure how aware the general public is, but primary care, social care settings are still adhering to COVID restrictions when it comes to isolation and staff. It doesn't fit in with the national picture. So practices, on top of people being stressed and wanting to leave or off sick for other reasons, we're still losing staff for 10 days isolation sometimes, because we're seeing patients who are just living their life as normal in general public, as they should be. But then in general practice, we're having to deal with the fallout of that, and it's really difficult. And some practices are losing 10 and 15% of staff for 10 days at a time, and it's not sustainable. It was just it's just an awareness comment, really, Terry.
Thank you, Nikki. Lee, please. Thank you for waiting patiently.
No, that's fine. And I'm really sorry I disappeared. My computer's never done this before, but it's now all updated, so that's completely fine. Yes, to everything that everybody's said, really. I don't want to repeat everything. I suppose one other thing that I would say is that we're not in primary care, because of the demands and because of the changing workforce, we're not just looking at new ways of offering appointments and new ways of doing what we've always done. Actually, there's a lot of conversation about new ways of understanding what health is and what illness is. And actually, it's not all about needing a prescription or even to see a health professional. Sometimes it's about our lives and our communities and our housing and our jobs, and there's a much greater understanding of the holistic nature of us as individuals. And I think that, there's a lot of conversations happening in primary care about that, which to me feels really innovative and exciting. And it would be really helpful to have those conversations in secondary care as well, I think. So there's a lot of enthusiasm and a lot of positivity about that, which sort of sits against the negative, worn down aspect of health, which I think we all understand as well, and it's balancing both of those. I suppose my only note of caution is when we get excited about hearing what Manor and Castle have done and the huge impact they can have, the numbers are very small. I heard, 138 people were involved. Well, first part, there's 10,000 patients, and a huge significant proportion of those are living in poverty and are having terrible health outcomes. And so when we're thinking about new ways of working, it's definitely the direction of travel to go in, but we've got to really understand the scale of the problem as well. And small pilots here and there probably aren't going to make a big difference. We've got to really think big.
Thanks, Lee. Recognising Zach, you've been waiting really patiently. I'm just going to ask if you could just reflect on one thing in specific. So I think if we look at risk 3.3, which is about the inability to secure active engagement and participation and involvement of clinical directors from the CCG's member practices and relevant CCG teams. That's one of the lowest scores. We've seen some progress on that. And I just wonder, Zach, if you've got any reflections on how we've managed to make so much progress in mitigating that risk, and what you think the effect of that might be in terms of dealing with some of the other higher risks. So in particular, what has the engagement that we've got with our practices got the potential to do in terms of it helping improve resilience and new ways of working?
Why do I never get the easy questions, Terry? No, I think it's multifactorial. I think if St John were here, he would say it's about managing complexity through relationships. As an organisation, we were in a very bad place a few years ago. We've worked really hard to be very value driven. And I think that is actually spread out. I think the NHS relies on goodwill, particularly goodwill of clinicians that work within the NHS, just to go that extra mile. And you need to do that through relationships. So people need to be treated well. They need to be treated with a bit of respect. There needs to be a degree of understanding about some of the pressures that people are under. You need to have a bit of sort of constructive challenge and constructive criticism to get that change. But I think what we've achieved, and it is through relationships, is it's building that trust. It's individuals that are held in high esteem. So one guy that's here today is Greg, who was on a webinar with me yesterday. Our Director of Public Health is hugely visible within Sheffield and has been throughout the pandemic. And that really is valued by the practices and the guys on the front line, as they say. And I think it's that. So it is quite complex, and it is personal stuff. So it's not something that you can just parachute someone else in and suddenly you've got the same situation. So although it's much more secure because of the journey we've been on as an organisation, but because of a collection of individuals who've worked really hard to build the relationships across the whole system. And the big fear for me is, although general practice in Sheffield is very resilient, it doesn't take much to tip it. And when you're looking after 92% of the activity within that part of the sector, which at the moment, it does feel a little bit of open season against GPs at the moment, and morale is at an all-time low. There is always a risk that just a tiny shift in your ability to manage that activity could have a devastating effect on the rest of the system. And we tried to describe that in the paper we took to our HCP back end of last year. We've had a lot of support from the whole system, and I think more understanding since then. So it's stable, but it's always precarious, because I think so much of it is based on that goodwill bit. And the problem is, when you get hammered day after day, then the goodwill does eventually run a little bit on empty. And I think it's not far off that at the moment. So I think better position in Sheffield than many areas, but the same pressures across the whole country. And I think we're in a good position, but I think it does feel precarious is the way I'd probably describe it. The NHS feels very precarious at the moment, and to help it survive, we really do need the public to support us.
Thank you, Zach. I think on that note, I will close this item now, but thank you for everybody for detailed insights and contributions there. And I really just want to thank you for putting them in the context of that GBAF, and in particular, helping to bring that to life and explain why some of those risks go one way or the other in the context of what we do. I now move us then to item 13, so communications and engagement update. Over to you, please, Lucy.
Hi, thanks, Terry. My name is Lucy Ettridge. I'm the Deputy Director of Communications, Engagement and Equality. And I just have a very short presentation, which I will share, because I normally do a report, and this month I've just got a presentation. Let's have a look. Here we go. Can people see that?
Yes, thank you.
So actually, I do this quarterly, or probably every 4 months, and it's the last comms engagement update for Sheffield CCG governing body. So it's very short, and it just pulls out some of the highlights of the team's work and some of the things that we've really been proud of so far this year. So that's January to the end of April. So in terms of joint pieces of work, so comms and engagement have both been involved in. I think something that we're most proud of is that we invested in 27 voluntary community sector organisations, sort of a 3-4 months piece of work on different priorities. So lots of pieces of comms and engagement to deliver for us linked to our commission and intentions. And one of those was vaccines. And as you all know, that our model was investing in the voluntary community sector to get the message out to communities, to increase uptake, to help remove barriers to getting vaccines. And that's been incredibly successful. I'm going to say it again, and I don't think we should get bored of saying it, but Sheffield is the top core city in the whole of England for vaccines for first, second and third doses. And actually we help fund groups to encourage uptake. So the Evergreen offer, and what we're now calling, I suppose, the first booster. So we did that at the start of the year. And we also did, we trialled a sort of Facebook Q&A session with a couple of our board GPs, so Ben, who's here today, and Lisa, that isn't. And that went down really well on Facebook. We had a huge reach for that. Another piece of work that we funded voluntary community sector for was urgent care. So there's a big piece of community outreach work, so following the sort of education model with who we know in parts of Sheffield and with community groups in really deprived areas, and with people from ethnic minority backgrounds. So we know that people are our biggest users of urgent care and with the greatest health needs. So we really did it at community groups, did a great piece of work there. And that was complemented by a social marketing campaign. So some paid advertising on social media and some paid radio advertising to really start to educate what urgent care services we've got in the city and when and how people can use them. And also the annual report. So my team helped, Kath's team, pull that together and finesse it. A huge piece of work, which we've seen, we've been doing this for a long time, and I think we've only been doing it since January, is the comms engagement around the proposal to build those 5 new health centres. So this has included the pre-consultation engagement that finishes in the next couple of weeks, loads of comms, which includes print media, social media, and lots of translated materials. We attended 5 public meetings to discuss the plans, so to try and counter some of the myths and just really be there to listen to what people liked about the proposals and any concerns they might have. We've also been supporting the practices, there are 15 practices to engage their affected patients. And again, we're using our community voluntary sector model where we're paying community groups to go out and engage underrepresented groups on our behalf. So we've funded 3 groups for Vale Community Hub, SOAR and Shipshape, because they're some biggest groups in those parts of the city. So they're using lots of different methods and encouraging people to fill in surveys, and they will be translating them. And we've had about 1,800 so far, but say it's open for a couple more weeks. Just other projects, so social media, so we're still very active on that, and I'd like to highlight that Facebook followers have gone up by 76% in this period, which seems to, people really seem to be responding to what we're doing on Facebook. And one statistic I thought was quite interesting on Twitter, so people on average watch 14 minutes of our videos a day. And looking at media coverage, so a third was positive, and that was mainly about vaccines, a third was neutral, and a third was negative. And some of that was around delays to GP appointments and also the health centres. One of the big campaigns we delivered is a primary care social change campaign to try and explain to people why primary care is different to what it was pre-pandemic. Nikki was talking about actually some of the isolation and protection measures we're following, and just trying to encourage people to, again, use primary care services appropriately. And commissioning, engagement, as part of the voluntary sector work, we've done a piece of work on our commissioning intentions for this financial year, and we've heard from 1,500 people. So Sandy and her team are going through that, looking at actually what the needs of the population are and what their priorities are. We've done something around phlebotomy, which will inform some options on what blood services look like in the future in the city, neurodevelopment, and my team also shared a lot of our insights into a piece of work that Greg's team's done on inequalities COVID impact review. And that's just an example of the primary care campaign. A question a lot of people, young people, obviously not me, who would say, I can visit a nightclub, how come I can't get a face-to-face appointment with my GP? So just going through some of the thinking around how primary care is organised, keeping people safe, limiting the numbers of people that go through the door. So next 2 months, taking us through May and June. So we're going to finish the pre-consultation engagement on the health centres work. We're going to do the options appraisal and get that into a good position to consult come early July. So we're going to prepare all that. We're also going to launch pre-consultation engagement on the future of adult speech services in the city. We're going to refresh that primary care campaign because it's been around a few months now. So we need to just evaluate that and see what we can do differently. And we also want to do lots of PR around GP services and primary care, because I think a few people have touched upon today how primary care, there's a lot of criticism in the media, and we know they're doing fantastic work and working really hard. So we want to highlight some of that. The team are also working on CCG close down, and as part of that, we also want to do some of the celebration comms, so what we're proud of for the last 10, 11 years. And also we'll be supporting Integrated Care Board on the startup projects, so including Day One Comms. So my team's involved in that, and also the digital programme, get a new intranet, website, all those things up and running for the 1st of July. So I will stop there and happy to take any questions.
Thank you, Lucy. I think it's a really comprehensive review of what you've been doing this year, and just considering the absolute breadth of what the team is doing and the organisation is doing. Are there any notes or any considerations anybody wants to bring up, or any questions at this stage? So Chris, please.
Thanks, Lucy. It's good to see that all together, and particularly building on some of the very strong links with communities for the social change and primary care one, and also understanding from the public health report about the inequalities over COVID, which is really up-to-date report. So I think it's really important area of work in terms of moving into our, the new ICS, ICB and the place structures to build on that area. Are there particular areas that you think are particularly key for because the public does need to understand that some of the structures are changing. I know it's at their point of receiving the service that shouldn't change. is there opportunities to build on this in terms of the communication about what's happening in the NHS? Because people can get quite concerned that they're not going to be able to get what they might have been used to, and that also applies, I think, to the great investment in terms of the estates and the consultation you're doing, but sometimes people may not see that that's going to be a good thing, and it might mean something that they're going to find difficult. So I don't envy your job at the moment, it's probably what I'm saying, but I can see some of those things, although they're good and moving forward, we still need that communication role is really key, so it doesn't end up being an investment that gets a lot of bad publicity. You see what I mean?
Thanks,
thanks, Chris. So Lucy, just in the interest of time, if I can take questions from Mark and Ben, and then maybe you'll be able to respond in the round to those, if that's okay. Thanks. So Mark, please.
It's not a question, I'm afraid, Terry. It's just a statement, which is, I mean, I just want to say, as the chair of Strategic Public Involvement Experience and Equality Committee, it's been a real privilege to work with our communications and engagement team, who I think have been excellent. And it's not just me saying that. We are rated, I didn't spot this in the annual report, maybe this is because it was last year, but we are rated one of the top clinical commissioning groups in the country in terms of our work on engagement by NHS England. That's in an external assessment of our practice. And it's there for a reason. And some of the things we've heard about quite often today, the way that engagement is stitched into a whole range of things that we've been talking about in this trustee board. It's not just sitting there. There is this separate report, and rightly so, but it's also come up in a whole range of other areas in terms of how we relate to the voluntary and community sector and members of the public. And I really hope that this is not lost as we move forward into the new world, and not least because we don't know who our new place director is, but they actually, I hope, are going to come to us, whoever they are, with a humility in terms of seeking to understand our history and why we are working as we are working now. So I think I'll just say that. That's it.
Thanks. Ben, please.
Also, can you hear me again? Also not a question, comment, but just to say, I think this comm stuff is so valuable, and we've just, in light of everything we just said about how challenging it is in primary care, and we often a bit stuck for solutions, comms is one of those massive solutions, because what we lose when we're overwhelmed is that one-to-one communication can sometimes be very stretched. And then the comms team is what can communicate to hundreds and thousands of people all at once, and helping them to understand the changes, helping them to use the services in a way which works for them and works for us. And I think that's just really valuable. And then also just to reflect on the engagement with the voluntary sector, those it's just so innovative and brilliant, and both in terms of improving health inequalities, but also that just really complicated problem that keeps coming up when I go to my PPG. It's like it's one thing being able to communicate on the internet, but what about everyone who's not on the internet? And it's such a difficult one to crack, but that engagement you do with the voluntary sector is just brilliant in terms of relationships, and word of mouth is the other arm that you need. And it's just, absolutely brilliant. So it's just such important work.
Thank you, Ben. Lucy, given that there weren't two questions there, I'm going to bring Judy in for the final bit, and if that's not a question, I'll get you to respond to the first one. Judy, please.
Thank you. It's kind of a question. So earlier, Gavin, you were talking about when we saw the video, how important and what that demonstrated to you, and how important actually truly working with voluntary sector services who do work closely with the population. And I think, and I hope, what you've seen from that brief presentation from Lucy is that the CCG has a track record of actually building that relationship, which we've talked about being really important with the population, and moving towards that co-production. And I think I heard you say that was something that for you, in terms of the ICB, that's really important. So like Mark, I hope, and I would like to have some assurance that kind of that voice is going to be part of what makes up that board. And I don't know if you're able to comment on in terms of what that might look like.
So, Gavin, are you able to respond?
Yeah, thanks, Terry. So, I mean, probably not much more to add, Judy, to that which I said before, other than it's incredibly important. But that whole piece of, you know, how do we authentically engage with the communities we serve is absolutely fundamental to what we're trying to do. And I do see, you know, particularly the VCSE as a huge ally in enabling us to do that. So, I mean, I think, you know, I mean, that's what I think. I mean, you know, if you think about this on a South Yorkshire footprint, I mean, my impression is that, you know, the places, the communities are quite different. They're quite diverse, and you know, I think you have to engage with people on their own terms. And I think in some ways, you know, there's some great examples there about how we're using the VCSE to do that. Because I think generally, I mean, people who volunteer come from those communities, are part of those, or you know, kind of understand, you know, the right way to engage, the right way to communicate, to get the message across, but also to get to collect the views as well, to kind of, you know, engage people in a genuine way and trying to shape what we do. But it has to be right for those particular communities. And you know, if you take a place like Sheffield, I mean, it's nonsense to think of Sheffield as though it's a place really. It's you know, there's massive diversity within the city. So I mean, you know, I'll probably sort of wax on and on about this, but I do think it's crucial. I think the other thing I would say is, and not just in relation to engagement, but actually it's really hard. This meeting's been really heartening, and looking at the annual report, and you know, this is about building on the foundations that have been laid. It's not about, you know, starting something new or as if it's a blank sheet of paper. This is a build. It's not a change.
Thanks, Gavin. Lucy, I don't know if you remember the original question, because I think I've forgotten it now, but if you're able to respond to that question that Chris put down, that would be great.
I think there's 2 points. I think you're asking me, Chris, out of all of that, what do you think is most important to keep and build on? And I think other thing is, how do we communicate with the public post-July? So I'll take the first one, and it's very much what Gavin said. So in Sheffield, we've been working hard, and it's been through a speak on what the model of engagement and experience and equality will be. And I think it's very much built around funding, sustainable funding for voluntary community sector to actually go out and listen to the public and bring those views back in to shape our decisions. And we piloted, so we've done lots of ad hoc projects. And so for the first 3-4 months of the year, we gave them a bit more funding to do 4 projects, and then we're evaluating that, because that's what we really want to do, and we want to get into an annual programme of work and building money for infrastructure and everything else that they might need. But so they know, and they can plan their capacity, their staffing, everything they need to do for a whole year. And rather than us go in 3 weeks with 3 weeks notice saying, can you do a bit of work for us on flu? Can you do a bit of work on phlebotomy? They can actually plan it in, and they can get to those people with the greatest health needs. So that really will be at the heart of our engagement model, if we can do what we think and we know is right for Sheffield people. So hopefully, you know, Gavin, we're not going to go for that centralised model, because actually what's right for Sheffield, you know, will be different to what's right for Doncaster and what's right for Barnsley. So I think that's the most important thing we really like to keep and that we're proud of. And public comms, well, it's the comms people to work with Gavin on this, because for me, I think it's about reassurance that actually nothing's going to change. It's a big organisation's coming, so the 1st of July, people are going to be able to access the same services they always have. So it's the so what, it's bringing it to life. So actually in the first year, the first 3 years or first 5 years, what will be different? And I think it's really trying to break down integration. So why is this big reorganisation happening, and what is benefit to staff, what's the benefit to the system, and what's the benefit to the public? And that's something we need to work through. I think nationally they're going to bring some lines, but it's reassurance and also just actually bigging up that actually this will improve health and it will improve people's lives, because ultimately if we're not going to do that, then we've failed. So I think, yeah, it's nailing those messages really, and we're not quite there yet. But as soon as we've got anything drafted, I'm happy to share with governing body. Does that answer your questions, Chris? I think.
It's nodding away. So
Thank
thanks, Lucy. I think there's some really important points. So I think, you know, that shift to really working with people in communities and the organisations that know them best. I think that has been an absolute significant achievement. You know, really want to recognise the comms and engagement team, and in particular just recognise Mark here, because you've been a bit like a wasp in a bottle. You have not let this drop in all the time that I've been involved, and you know, that driving force to push that forward, I think is really important. So for me, I think, you know, perfect looks like not the voluntary sector, you know, like you say, Lucy, being there, that we give small grants here and there, but actually being a true equal and strategic partner in engaging with our communities, and sort of, as you say, gathering that information back so that we can make much better decisions about what we do in the future. So thanks, Lucy, for your report.
Sorry, thank you. Can I say one thing? Yeah, I agree with that. Actually, Mark has been a brilliant champion and ally and a great chair of Speak. So I think as our last sort of governing body that will talk about Speak or engagement, I'd like to say that. So yeah, he's been brilliant. So thank you, Mark.
Thank you. Okay, right. Recognising that we've had quite an in-depth discussion on those last two items, and our agenda has slipped a little bit, but I think there were really important perspectives for us to dive into in a bit of depth. So final big item on the agenda is integrating care update. So I'm going to hand over to Gavin, please.
Thanks, Terry. So, I mean, as you said when you introduced me earlier, I mean, I'm in a slightly unusual position in that I'm here as the interim AO, but I'm also the chief exec designate of the Integrated Care Board, which, given that the Act received royal assent last week, is on track to happen for the 1st of July. But before I get into, you know, kind of what we're doing, I think it's worth, you know, anybody who knows me knows I like to start with the why. You know, why are we doing this? You know, this is about joining up health and care. It's about joining up the providers of health and care, trying to deliver a seamless service that you know, that basically meets the needs of the people that we're here to serve. And I mean, I've worked in the NHS for a long time, and for a long time, I've always thought that it seemed to me that policy was kind of almost you know, maybe people apart, but for the first time, this feels like a direction that I can certainly embrace personally, because it's about joining things up. So I think I feel really passionate about it. The four aims, I've sort of touched on them earlier, but it's about improving health outcomes. It's about addressing health inequalities, the sort of things that we heard right at the start of the meeting. It is about, you know, we've heard from Jackie some of the financial challenges we face. It is about how do we maximise the value that the public get from their taxes in terms of you know, the delivery of services. And the fourth aim is around this notion of you know, the anchor institution. I mean, health and social care in South Yorkshire is a huge industry, really. 72,000 people work in health and care. You know, you know, our responsibility to South Yorkshire is much greater than just our role to deliver health and care. We're a huge employer. We've got an opportunity to be a beacon for what it looks like to be a good employer. You know, we consume resources, we procure, we buy things. You know, it's an opportunity to use that purchasing power for the benefit of you know, the kind of the wider economy here in South Yorkshire. So that fourth aim, I think, is really important. So I suppose the last point, you know, the NHS and care is a polluter as well. That's something like 5% of all greenhouse gases within the country are generated by the NHS. So we've got a big responsibility as well to think about how we might do our business differently to help you know, meet you know, some of those challenges too. So that's why we're here. Clearly, there's a lot to do. So the 1st of July suddenly feels extremely close. I'm conscious from a people perspective. You know, we're trying to do two things. You know, obviously the clinical commissioning groups are stood down as a result of the Act, and the ICB is stood up. So managing that transition from what we've had in the past to what we move to in the future is a challenging thing from a people perspective. So we are trying to do that as well as we possibly can. One of the things I'm particularly keen to do is to involve all of our colleagues, my colleagues, currently working in the CCGs, for example, in a conversation about what we want the new Integrated Care Board to be about. What does it stand for? What are our values? How do we behave with each other? How do we behave with our partners and the communities we serve? And I think laying those foundations, building on what's gone before, is really important, because it's that which will get us off to a good start. So I just wanted to say that at the beginning, Terry, but I'll briefly just give a sense of some of the practicalities. So clearly there's a transition of functions from the CCG to the ICB. So there's quite a detailed process that we're going through to make sure that we capture all of those issues. We've looked at the BAF, for example, earlier. Those risks don't disappear on the 30th of June, unfortunately. So part of that process needs to be, well, how do we make sure that we keep sighted on those risks as we move forward into the new organisation? But all of the things like the financial systems, digital systems, all of those sorts of things, we've got to work through. There's practical things like setting up the new organisation, the board. We've been through a process to recruit to that board. We're making good progress. I'm hopeful that by the 1st of July, we'll have that more or less populated. There's some structures that I'm particularly keen to support. Most importantly to me are the place partnerships. So how do we, here in Sheffield, how do we bring everybody together, the local authorities, the providers, the VCSE, healthcare organisations together, to progress this notion of integrated care. We've just appointed an executive place director, which will sit on the board of the ICB. Not every system in the country has done that, but we really wanted to make sure that there was real horsepower and an ability to delegate resource and decision making into places. So I think by doing that will help us. So we're getting the board together, we're getting the place partnerships together. We're also talking to provider organisations across South Yorkshire about how we accelerate their journey in terms of the creation of those cross-system structures, such as the acute federation or the mental health federation, which seeks to integrate services across South Yorkshire in that way, whilst at the same time playing a full part in the place partnerships such as here in Sheffield. And the final part of the puzzle that we're focused on is the final structure is the Integrated Care Partnership. So this is an inclusive body. It's a partnership that will be convened jointly by the local authorities in South Yorkshire and the ICB, but to bring together a broad spectrum of voices from the voluntary sector, NHS organisations, other stakeholders that are involved in, I guess, what we describe as the wider determinants of health. So whether that's employment, education, housing, those sorts of voices as well, because all of these things have a big impact on the health of a community. But it's this body that will set the strategy for the ICP rather, will set the strategy for the integrated care system in South Yorkshire. So getting those arrangements in place, I think, are particularly key. And one of the things that myself and Piers Butler, who's the designate chair for the Integrated Care Board, have been doing recently is talking to the health and wellbeing boards who've been working in this space within within Sheffield, within Rotherham, Doncaster and Barnsley, to get their views about how that integrated care partnership ought to be constituted in order to enable it to deliver or to develop that strategy so that we, together with our partners, can deliver it. But Terry, I'm going to kind of pause there, but happy to take any questions or comments.
Thank you, Gavin. So any questions? Mark, please.
Am I allowed out of my bottle?
You are indeed.
That's really helpful in terms of going forward. The only thing I suppose I would say is it's really useful to have, I think you mentioned 5 sort of areas of focus. that the ICB is going to be focusing on quality, health inequalities, value, economic impact, and sustainability. Really, the NHS is a polluter. I think it's just really important that this is the iteration that's being used at the moment, but all of those things are not new. That's stuff that, and in fact, we've heard the annual report, and you can look through that, and possibly with an explicit statement about economic value and polluter. Certainly in terms of the responsibilities of the CCG, equality, health inequalities, value for money are all things that have been not just the responsibility of the clinical commissioning group, but of its many predecessors. So I think, and it's important to recognize that, because we're not starting from square one. And indeed, we've had some gains on some of those, but also there are plenty of areas to address. I think what is key for the new IC integrated care system, ICB and ICP going forward, is that we're clear about the added value that this new structure is going to bring. And as we know, and we have spoken about this in other fora, Gavin, the NHS, the governments of all shapes and forms, colours, decide to reorganise the NHS. Between 5 and 7 years, there's a new reorganisation. So in some senses, this is not some carefully planned process that has led yet again to another reorganisation. But nonetheless, those of us with responsibility in the system have to say, what is the added value? What can we wring from this? The previous configuration made it hard for us to do. And I think that is the bit that the ICS needs to sell itself on. And I think one of the key bits is around how it's going to bring together a shared ownership across different players within the system. And from the hospitals through to the GPs, through to dentistry, and that's a tricky area now, pharmacy, voluntary sector, local government, etc. That is where it's going to be measured. And I think it is urgent that the integrated care system starts to talk about the added value that that process is going to bring to the world in which we're in at the moment. Thank you. Going back in the bottle now.
Done, Mark, back in the bottle. Thank you. Lee, please.
Sorry, I just can't get that image out of my head. Yeah, thanks, Gavin. That's been really helpful. And I think this is a conversation we've had before, but I think it's really timely to keep this in mind about that tension between targets and outcomes, and how we as a local place and region manage that. Because we know that centrally, central government is really fond of targets. And people on the ground will be equally cognizant that actually targets often produce really poor outcomes. They produce what you don't want to achieve. And we have to be mindful of that. And because my computer crashed out during the performance and delivery report, one of the things I was going to say was all that red that we were seeing, all that red, we can only begin to imagine what that must feel like to be working within that secondary care system where the targets are just a distant dream, and yet the pressure is on to achieve them. And we know that what they represent is a lot of unmet need. And so, we're a caring profession, we want to meet that need. But what the default tends to be, we fall back to doing what we know how to do, and we just need to do more and more and more and more of it. And that absolutely is not going to cut the mustard. It is not going to meet that need. We've got to be really innovative and think of very different ways of managing, particularly if we think about outpatient appointments. The letters I get back, I think, well, what benefit was it for that patient to go to hospital at that point? Often there isn't, but when we're under pressure, it's really hard to think outside the box and think differently. And in a sense, as a system, that's what we should be facilitating and enabling. And I suppose I'll save you a bit of time later, Terry, on the papers for noting. My heart sank when I read the HCP strategic report, the update. So in response to the urgent and emergency care, the question was, well, how can we improve the percentage of appointments in general practice within the first 24 hours? And I understand where that's coming from. but actually that is not what is needed. And there's a real tension between access and continuity of care. And when we're dealing with complexity, then continuity of care is really, really important. And if I think of an average surgery that I do, a very small number need to be seen on the day. The vast majority actually are much better dealt with seeing somebody that they know, that knows them, and managed in a much more holistic, considered, thoughtful way. But I see in that one report that tendency to fall back on meeting targets, urgent 24-hour access, and actually the outcomes are going to be the worse for that. So this is a very long way of saying, where do you sit in terms of managing that tension and doing the right thing rather than the mandated thing?
Thank you, Lee. I'll give you a brief response if that's okay, Gavin, because I think we could probably do a week-long seminar on some of those questions, Lee, and they really are big questions, aren't they? But Gavin, I'll give you the opportunity to respond before we move
briefly, on. I mean, some two good points from Mark and Lee. I think just in response to Mark, I think it's not. I don't want to get obsessed by the new structures and the new arrangements, because that's not what it's about. There's something about this is a change. I think this is quite a change in approach. So if I take Lee's question, I've been in the NHS for 30 years. I've never heard so many people talking about health inequalities as they are today. And I think that's what's really exciting about this. It's not the new structures. It's the fact that we're actually beginning to get serious about things which really matter. The point about targets, I mean, I'm not going to say that the government are suddenly going to relax on targets, etc. That will be here. But the two things are not mutually exclusive. I was looking at some fantastic data this morning about pressures in urgent and emergency care and attendances at ED, but it was expressed in terms of deprivation. And actually what you could see is quite a differential experience between those people from the least deprived areas versus those from the most deprived. So actually I think there's a genuine opportunity to use the lens of health inequality to actually address some long-standing challenges that we've had in the NHS that we try to approach in a particular way. But actually, if you look at them through a health inequalities lens, I think there's an opportunity there to do to really do something different. And that's just one example. But if you take waiting lists, for example, it's another target, but we know that if you're from one of the most deprived neighborhoods, you're twice as likely to wait longer than a year for an operation. So there's something going on here. And what I think is really exciting is, for once, as an NHS, we're facing into this issue of health inequality. So I don't think we'll. I guess there is a tension, if you view it like that. I'm a glass half full person. I mean, I actually see it as an opportunity.
Brilliant. Thank you, Gavin. So I'll close that item there and just take us then on to part 5 of the meeting. There were several reports circulated in advance for noting. Is there anything anybody wishes to raise about any of those papers? No. Okay, thank you. I've not been notified of any other business in advance. So I'll bring us then just onto the final part of the meeting. Just if we could have a couple of volunteers from governing body to highlight one of their key reflections from the meeting. What are you going to go back and share with your teams? What will you go back and share with your patients and your community? So any volunteers? No, I'm going to, Marianne, you usually come up with a wonderful reflection from us, so I'm going to volunteer you. I've got you on mute. Don't want to miss it.
Is that better?
There we go. Thank you.
Primary care is open for business. We're here ready to help.
Thank you. Brilliant. Okay, anything else? No, okay, I think we'll finish there on that reflection. Thank you, Marion. Our next public meeting will be a short public meeting on the 26th of May, starting at 2 o'clock, running until 3. And that will be when governing body is going to be asked to approve the CCG's fully audited annual accounts and the annual report for 21-22. The next full meeting in public from governing body will take place on Thursday, the 30th of June at 2 p.m. Details of how to join the meeting will be available on our website. As always, any members of the public still watching at this point, we encourage questions and comments in through our governing body meeting, and the details of how to do that are either on our website or you can write directly to the CCG. So thank you, everybody.